Hi everyone, I'm Dr. Roman and I'm a board certified hematologist oncologist, and if you or someone you love has been diagnosed with lung cancer and you are serious about learning about lung cancer, then I promise you this is the video that you have to watch. My goal with this video is to prepare you so that when you sit down with your doctor, you know exactly what's going on, what questions to ask, and you can take control of your treatment plan. So with that being said, let's get started. So the first thing I want to tell you is that this video is for educational purposes only. Always consult with your physician. All right, so let's start off with a brief overview of everything we are going to cover. And I promise you, I will prepare you so that when you see your doctor, you know what's going on. And we are going to go over the different types of lung cancer, the anatomy that you need to know, how do we make the diagnosis, the staging, in other words, how do we figure out how advanced your cancer is, the different treatment options, and something that's very important that's called biomarker testing that you must know about. Now, throughout these presentations, I'm going to be giving you questions that I would ask if I was a lung cancer patient. And I want you to remember, I am a cancer doctor, and these are the questions that I would have if I was a lung cancer patient. So my suggestion, you may consider obtaining a piece of paper and a pen and jotting down some of these questions so that you can ask your doctor. All right, so the first thing we got to go over is the different types of lung cancer. How do we divide lung cancer? Well, just know in its simplest form, we divide lung cancer into two types. The first one is a small cell lung cancer. The other one is a non-small cell lung cancer, okay? Now, non-small cell lung cancer is much more common. Now, small cell lung cancer, there's really only one. And if you've been diagnosed with lung cancer, just find your pathology result and it will either say you have a small cell lung cancer or a non-small cell lung cancer. And the way you know if it's a non-small cell lung cancer is because there are different types of non-small cell lung cancer. For example, an adenocarcinoma, a squamous cell carcinoma, which are these two by far are the more common types of non-small cell lung cancer. And then there are other types which are much more rare. For example, an adenosquamous carcinoma, which has features of both adenocarcinoma and squamous cell carcinoma. And another type that is called a large cell carcinoma. So these four, okay, are all types of non-small cell lung cancer. And this video is on non-small cell lung cancer. So if you've been diagnosed with a small cell lung cancer, then this video does not pertain to you, okay? This is only for those of you who have non-small cell lung cancer, namely an adenocarcinoma or a squamous cell carcinoma. I want to make sure that's clear. Now, I want you to know that for the most part, we treat all of these very, very similar, okay? There are some minor exceptions. As an example, there's some treatment, some chemotherapy that we can use in an adenocarcinoma, but not in a squamous cell carcinoma. But for the most part, we treat them the same, okay? So let's get started with non-small cell lung cancer treatment. So let's start off with the anatomy. And trust me, you need to know this, because if you don't know these basics, then you will be lost as to why they're recommending the treatments that they're recommending and what is going on, okay? So let's start off with the lungs. So these here are your lungs. This is your right lung over here, and this is your left lung over here, okay? That's lung tissue. This is your windpipe. So this is the trachea, which then is divided into your bronchus, your right bronchus and your left bronchus. And then these smaller little divisions coming off of your bronchus, those are your bronchioles, okay? So air comes in through your trachea, then in through your bronchus, and then into your bronchioles. And remember, your lung functions to bring oxygen into the body and get rid of carbon dioxide, okay? That's the function. Now, our right lung is divided into three segments, three lobes, okay? That's what we call it. This is your right upper lobe, your right middle lobe, and your right lower lobe. And these are divided by fissures. Okay, this is a fissure and this is another fissure. So on top of this fissure here, your right lobe has two fissures. This is your right upper lobe, right middle lobe, and then down here, your right lower lobe. Very important. You need to know this. Your left lung has one fissure, and it's divided into your left upper lobe and your left lower lobe. You will need to know this, especially when we talk about the surgical treatment of lung cancer, okay? So now you know your right lung has 3 lobes, your left lung has 2 lobes divided by the fissure, okay? Now, these green objects, these little bean-shaped green objects that you see all over the place, these are lymph nodes. Lymph nodes are part of our immune system. Now, the important thing, the reason you need to know about lymph nodes is because lung cancer starts in the lung and it loves to travel to lymph nodes. And then after they go to these lymph nodes, they spread to other areas of the body. So you need to know about these lymph nodes because throughout, when we discuss the treatment options, especially during surgery, we want to know, are your lymph nodes involved with cancer? Okay, so something very important that you need to know. The other thing I want to go over, this middle area here of your chest, okay, where your trachea is, I don't know if you see the little pointer here, that is what we call anatomically your mediastinum. That is the middle of your chest where the 2 lungs are found right in the center where your heart is located. That is your mediastinum. And I just want you to remember that because I will refer back to this in in some of these future slides that we are going to go over, okay? The mediastinum is the middle of your chest. This that you see here, this is a lung cancer. I just wanted to illustrate this to you. And this down here, this is another lung cancer. Notice that this lung cancer is more towards the center of the lung, the middle of your chest, whereas this lung cancer is more towards the periphery, more towards the outside of the lung. The only reason I'm showing this to you is that in general, okay, this is not always the case, but in general, lung cancers out in the periphery tend to be an adenocarcinoma, whereas in the middle of the chest or the middle of the lungs closer to your mediastinum, they tend to be squamous cell carcinoma. But it's not always the case. You can find an adenocarcinoma towards the mediastinum and a squamous cell carcinoma out in the periphery. But statistically speaking, we do see that the squamous cell are more common towards the middle of your chest, okay? So let's move on now that you are familiar with the anatomy of your lungs. Okay, now in this slide, we're going over the metastatic sites. So remember on the last slide, I told you that lung cancer develops in the lung and then it will spread to lymph nodes. And then from the lymph nodes, it will spread to other areas of the body. And I can tell you that lung cancer prefers to travel to or metastasize to certain organs. And I want to go over the more common sites of metastatic disease. The first one that you need to know about is your adrenal gland. Okay, now if you refer to this illustration here, you will see these are your kidneys, okay? Sitting on top of your kidney, you have this triangular shaped gland. Those are your adrenal glands, and lung cancer likes to travel to your adrenal glands. So when they perform the CAT scan or a PET scan or whatever picture of your body looking for lung cancer, you want to make sure they are evaluating your adrenal glands. Now, your brain is another site that your lung cancer may travel to, so your doctor may recommend a CT or preferably an MRI scan of your brain. Lung cancer can also travel to your bone, to your liver, and believe it or not, to other areas of your lungs. So you can have, for example, a lung cancer on your right lung, and that lung cancer can travel to your left lung. Or maybe you have it on your right upper lobe, and it can travel to your right lower lobe. That's why you need to know the anatomy and basically understand that lung cancer can spread, and you need to know that these are by far the more common sites that lung cancer spreads to. All right, now let's go over making a diagnosis, okay? So if you've already been told you have lung cancer, chances are you've already had a biopsy done. Now, if you've had, say, a CAT scan done and they found a lung mass, then obviously we want to obtain a biopsy. In other words, obtain a little piece of tissue so that we can look at it under the microscope and decide, number one, do you have a lung cancer? And what type of lung cancer? Remember, is it a small cell? Is it a non-small cell? And if it's a non-small cell, which type? Adenocarcinoma, squamous cell carcinoma, etc. So there are different ways that we can obtain a biopsy depending on where is the mass located. So the first one, for example, is what we call a percutaneous needle biopsy. So if you have a lung mass that is closer to the periphery of the lung, then we can put in a needle through the skin into the lung and obtain a biopsy that way. Now, what if the mass is inside closer to your mediastinum, okay? And then putting a needle through the skin is very difficult because we'll have to go through almost the entire lung to get to that mass. Well, another way we can do it is what they call an endobronchial ultrasound. They'll put a tube either through your nose or through your mouth into your airway, and through ultrasound, they will try to detect the mass, and then they'll insert a needle through your airway into the mass and obtain that biopsy, okay? The goal is to obtain tissue. So that's another test they can do, especially if the tumor is located more centrally, closer to the mediastinum. See, that's why you need to know the anatomy of the lungs. The other one is, as the name implies, remember your mediastinum? Well, a mediastinoscopy. That is inserting a camera inside your mediastinum. The surgeon will make a small incision above your sternum, okay? And they will go into your mediastinum and obtain a biopsy using a camera. So the goal here is to obtain tissue to make a diagnosis. So one question that I would have, if you have a lung mass and you have not yet had a biopsy done, is which one of these methods is the best approach to obtain a biopsy? Okay, so now let's move on. So staging. When we finally know that yes, you have a lung cancer, we definitely want to stage you. This means we want to know how advanced is your cancer, because depending on the stage, the treatment will differ, okay? And there are several different tests that we can use to stage you. The first one is, for example, a CT scan, also called a CAT scan. And we want to scan your lungs and your abdomen. Remember your abdomen because we want to look at your liver, and remember the adrenal glands, okay? And for this, you need IV contrast, okay? Another test is a PET scan. A PET scan will look tumor throughout your body because this is a test that's using glucose. And then wherever you have tumor, usually the tumor will eat up that glucose, and then a fluorescent molecule will light it up, and we will detect it on a PET scan. It's actually a very good test for lung cancer. Now we also have PET CT scans. So it's both in one, okay, a PET CT scan. Another test that we may perform is an MRI scan of the brain. Remember, lung cancer can travel to the brain, so your doctor may recommend an MRI scan of the brain. This is mainly done if you have what appears to be a little more advanced lung cancer, or if you have neurological symptoms, like let's say you're having blurry vision, or you're not having a coordination, or you have weakness in one arm compared to the other. This may suggest that maybe you have something going on in your brain, so we definitely want to scan your brain in those cases. Okay? Another test could be the ones that we mentioned before to obtain a biopsy, which were the mediastinoscopy or an endobronchial ultrasound. Think about it. Let's say you have a mass in the middle of your chest and we're not sure if there's cancer there or not, okay? Another option would be to obtain a sample. We can obtain a biopsy, and obviously if we figure out that yes, that mass is cancer, then that can aid us into establishing a better stage, okay? So the question to ask once these tests are done is, what stage is my cancer? And I have to tell you, this is one of the first questions you have to ask your doctor. The first one is it lung cancer? What type of lung cancer? And then what stage of cancer am I? And lung cancer is divided into 4 stages. Stage 1, 2, 3, and 4. Stage 1 is very early stage lung cancer. Stage 2 usually means that the lung cancer is a little bit larger, but it is still fairly early stage. Stage 3 usually means that cancer is already within the lymph nodes of your mediastinum. That's the usual scenario, okay? So the cancer has gone from the lung to the center of your chest. There's some slight differences, but as a general rule, that's what's happened. And stage 4 is the most advanced stage of lung cancer. It means that the lung cancer has spread to another area of the body, like for example, the adrenal glands or the liver or the brain, etc. Okay, so definitely what stage of cancer is the question that you need to ask. Now I want to take a little time to go over what a pleural effusion is. So if you refer to this diagram here, this is the lung, and between your chest wall, okay, your chest wall and your lung, there's a space. That space is called your pleural cavity or your pleural space. And your body normally has a small amount of fluid within that space, and that acts as a lubricant because as you breathe, your lung and your chest wall are in motion. So it works as a lubricant because you don't want friction as you breathe, okay? Now, sometimes, especially if the cancer is towards the periphery of the lung, okay, it can produce fluid. And you can have cancer cells within this fluid. And this is what we call a malignant pleural effusion, okay? And if you notice, this is the lung, and you can see the fluid accumulating between the chest wall and the lung. And this is a pleural effusion. If you look at an x-ray, this is what it looks like. Notice how this in black here, the darker area, that's your lung, because air in an x-ray is dark. It's dark in color. It appears black on an x-ray. Notice how this lung is being compressed, and this whole whiteout area that you see here, this area here should have normal lung, but this is all full of fluid, and this is because of a malignant pleural effusion. So the reason I'm bringing this up is if your doctor's told you that you have a lot of fluid surrounding your lung, you may have a malignant pleural effusion. A lot of times they will tap it. They will do what's called a thoracentesis, and they will put a needle in there and they will drain it. Now, if they find cancer cells in that fluid, that's called a malignant pleural effusion. And there's a few things that I want you to know about this. So if you don't have fluid, you don't need to know about this, although it's good that you do, just in case it happens in the future, hopefully not. But the first thing is, if you have a malignant pleural effusion, by definition, you have stage 4 disease. Okay, so it's already considered metastatic disease. Surgery is not an option. Now, the other thing is, you may have the fluid removed because all this fluid putting pressure on your lung can make breathing difficult. It can give you shortness of breath. So by having a thoracentesis, that's when we put a needle into your pleural cavity and we drain fluid out, it will make breathing a lot better. Now, the problem is, if this effusion is malignant and you do not treat the cancer, a lot of times this fluid will reaccumulate. You will have a recurrent malignant pleural effusion. And I just want you to know that sometimes we give chemotherapy and this gets better, but sometimes it does not. And there is another option for you to consider. We can put in a catheter, okay? Sometimes, as an example, a pigtail catheter, what they call, and you can drain the fluid yourself at home. So it's a little catheter that you have in place, it's sealed, and then every so often, whenever you feel you need it, you can drain the fluid in your home, and they teach you how to do this. Another thing that you can have done is what they call a pleurodesis. And this is when we inject a chemical into the pleural space to seal off that pleural space. Okay, it just creates a lot of fibrosis and it prevents the fluid from accumulating there in the first place. And there's a few ways of doing this. We can inject a chemical. They can also inject a special type of talc, which is a powder in the area. The whole idea is to eliminate that fluid from reaccumulating. Again, I know that's a lot of information, but as I said, if you do not have a malignant effusion, this does not pertain to you. But if you do, I thought that that would be very helpful. Now, let's keep moving. So, if you have lung cancer, in general, you will deal with 3 different doctors, and you need to know this. The first one is a thoracic surgeon or a lung surgeon, okay? The other one is an oncologist. They're also called a hematologist oncologist or a medical oncologist. For example, that's what I do. I am a hematologist oncologist, and we provide chemotherapy, we provide immunotherapy, and in general, we are the ones that continuously follow the patient long term. And last but not least is a radiation oncologist. And this is a doctor that provides or gives radiation, okay? Definitely you will end up seeing a thoracic surgeon and an oncologist. You might end up seeing a radiation oncologist. But I wanted you to know the difference and the 3 doctors that you will be following. Now let's talk about surgery. Now I can tell you that for lung cancer, the most important treatment is surgery, okay? If caught early enough, surgery is the best treatment option that provides the best chance of a cure, okay? Now there's different types of surgery and you need to know this, okay? So you have an open surgery or you have what we call minimally invasive, and let's discuss the differences. So in an open surgery, it's also called a thoracotomy. So the surgeon will perform an incision on your chest wall and they will perform the surgery using their hands, okay? The bad thing about this is that it usually requires a larger incision and recovery time it's longer. It'll take a lot longer for you to recover because the incision is usually bigger. Now, minimally invasive, there's 2 main types of minimally invasive surgery, okay? The first one is what we call a VATS, V-A-T-S, and that stands for Video Assisted Thoracoscopy. The other is a robotic surgery. Now, the difference is here. In minimally invasive, the doctor will make small incisions in your chest and they will insert an instrument into your chest and perform the surgery using instruments. Now, in a VATS procedure, the surgeon is standing right next to you. They're using their hands, manipulating these instruments, standing right next to you. Whereas in robotic, they insert these robotic arms into your body through these small incisions, and then the doctor is sitting over on a table controlling these robotic arms, okay? The surgeon is not necessarily standing right next to you, okay? Both of these are types of minimally invasive. Now, the advantages of minimally invasive is that the incisions are smaller, recovery time tends to be faster. Now, I want you to keep in mind, if possible, of course, I would prefer a minimally invasive surgery, okay? But you might not be a candidate for minimally invasive. And I'll give you one example. Let's say your lung cancer is very large. And through that small incision, they just cannot take out that lung cancer. So in those cases, you may require an open thoracotomy, the open type of surgery. So the question that I would have, if I required surgery for lung cancer, and this of course you're going to ask your surgeon, is what type of surgery will I have? And of course, if the doctor leaves it up to you, minimally invasive, which one of the minimally invasive approaches, whether VAT or robotic, it all depends which one does the surgeon prefer and which one does the surgeon has more experience with. Because we know that the more experienced the surgeon is, the better the patient tends to do. Okay, so very important question, and I thought you should know all this. Okay, so once you've decided on what type of surgery you are going to have, let's say you're going to have a minimally invasive, well, the next question is, what are they going to remove? How much of your lung are they going to take out? Okay, and in general, there's 3. Number 1 is what we call a wedge resection, and that is, let's say this is the tumor, the surgeon will cut out a little piece of lung, okay? or a piece of a lobe. Let's say a piece of your right upper lobe as an example. That's called a wedge resection. The other type is what we call a lobectomy. Remember, your right lung is divided into three: your right upper lobe, right middle lobe, and right lower lobe. In this example, they have removed the right upper lobe of the lung. That is called a lobectomy. Now, over on this side, they're removing a whole lung, and this is called a pneumonectomy. Of course, a pneumonectomy is a much more complicated surgery with much more risks than, say, a lobectomy or a wedge resection. So usually a pneumonectomy we try to prevent, and the best option usually is a lobectomy, because a lobectomy takes out that entire piece of lung, and it tries to obtain what we call negative margins. And I'm going to go over margins on the next slide, so stay with me here. Now, why would a doctor do a wedge resection, only remove that small piece? And remember, if they remove that small piece, there's a slightly higher risk that they might leave some of those small microscopic cancer cells left behind. But a doctor may do a wedge resection. As an example, let's say you have severe COPD. Your lung function is very poor, and the surgeon may be afraid that if they remove an entire lobe, that you may become oxygen dependent, or that you will become what we call a pulmonary cripple. In other words, you could barely move without becoming severely short of breath. So the question to ask your doctor if you are going to go to surgery is, what will be removed? Am I going to have a wedge resection, lobectomy, or pneumonectomy? And as I stated, in general, lobectomy is the way to go if possible, okay? But ask your surgeon. All right, now let's talk about surgical margins, which I mentioned on the prior slide. And listen, you need to know this. And I want you to look at these pictures here. So on this side, okay, on the left here, you have, this is the cancer. And notice that the surgeon has taken this out. So in yellow is the incision that the surgeon made, what the surgeon cut out. This is right where the knife went through and they cut out. This here in pink, this is normal lung tissue. And look at the tumor. So if you notice, the tumor is surrounded by normal lung tissue. So the surgical margin, which is this yellow line around, is completely negative, meaning the tumor did not extend to the area that the surgeon cut out. Now, if you compare it to on the right, once again, this is the tumor, this is lung tissue, and this is where the surgeon cut. Notice that all this area here is clean, negative margin, negative margin. But if you notice, right up here at around 1 or 2 o'clock, the 1 or 2 o'clock area, the tumor extended to or beyond the surgical margin, okay? And the important thing here is that this area that you see out here stayed back inside your body. This is what we call a positive margin. Positive margins are not good. It means that cancer cells were left behind, okay? So if you had surgery and they removed your cancer, the next question is, was my margin negative? Another way of saying it is, was my margin clean, okay? Because if you think about it, if you have a positive margin and they left some cancer cells behind, that can grow back and become a tumor again, okay? So ask about your surgical margins. All right, so before we proceed, I'm gonna ask you for a little favor, and that is, if you find this video educational, if it's helpful, like the video, subscribe to my channel, and share the video. I guarantee you there are patients out there that would really benefit from watching this video, okay? So let's continue. All right, so now let's get into treatment. And I can tell you the treatment for lung cancer is complicated because there are many options. You can have several patients with the same exact disease and all of them treated a little bit differently. And it really depends on you and your doctor. But some of the things we look at, for example, is your stage. Obviously, if you're a stage 1 lung cancer, we're not going to treat you the same as a stage 4 lung cancer. Also, the patient's performance status. In other words, how strong is the patient? So as an example, if you're a physically fit 50-year-old, we're not going to treat you the same as a 95-year-old patient with severe COPD. So of course, we take all of these things into consideration and then we come up with a treatment plan. But in the next few slides, I'm going to try to simplify it for you so that you know what are the things that we look at and what is the overall, the basic concept as far as treatment is concerned. All right, so starting off with treatment by stage. And again, I'm going to break this down several ways, and at the end, it will make sense to you. So if you have early stage lung cancer, okay, it was caught very early, chances are you will have surgery, and then maybe we will give you chemotherapy with or without immunotherapy, sometimes. If it was a little more advanced, for example, let's say that the lung cancer was in your mediastinum, then a lot of times we will give you chemotherapy with radiation therapy, okay? And maybe we will decide against surgery. But this is complicated. There are exceptions, okay? And last but not least, if it's metastatic, meaning it has spread to another area of the body, then usually surgery is not an option and chemotherapy with or without immunotherapy is the way to go, okay? Now let's get into more detail. Now, treatment by stage. So as a general rule, ask your doctor, what stage of cancer do you have? And if they tell you you are a stage 1 lung cancer, usually the treatment will be surgery, and then sometimes we will consider chemotherapy and or immunotherapy. All right, it really depends which stage 1 lung cancer do you have. But as a general rule, as I said, stage 1, surgery, and they will consider chemotherapy and or immunotherapy. If you're a stage 2 lung cancer, once again, surgery is the way to go. And then most of the times we will recommend chemotherapy and immunotherapy, okay? Sometimes we may give you chemotherapy alone. It really depends on your case and the individual details of you. Now, if you're a stage 3 lung cancer, meaning the lymph nodes in the middle of your chest are involved, the more common treatment is chemotherapy together with radiation therapy. It's what we call concurrent chemoradiation without surgery. And then we will usually give you immunotherapy after. Okay, sometimes up to a year later, you will receive chemotherapy. Now, I'm going back to stage 2 and stage 3 again, because sometimes for stage 2 or stage 3, your doctors may decide to give you chemotherapy and immunotherapy first, shrink that tumor, and then have surgery. And then after surgery, give you more therapy. It's usually in the form of immunotherapy, okay? So once again, stage 2 or stage 3, sometimes instead of either getting surgery for stage 2 or chemoradiation for stage 3, they may opt to give you chemo and immunotherapy first, then surgery, then another type of treatment, usually immunotherapy afterwards. So again, there are options, okay? I'm not trying to stress you out here. I'm just letting you know that there are options, okay? And that's a discussion that you have to have with your doctor. And of course, as I already said, stage 4 disease, chemotherapy with or without immunotherapy, or what we call targeted therapy, which I will get into shortly. So the questions that I would have here is, based on my stage, what treatment plan are they going to go with? For example, am I going to go for surgery off the get-go? Am I going to get chemotherapy and immunotherapy first and then surgery? You know, am I a candidate for stage 3? Am I just going to receive chemoradiation? That's the discussion and the most important question when it comes to treatment that you will have to ask your doctor. Okay, so let's move on. Okay, now let's take a little moment to talk about radiation therapy. And in general, radiation therapy uses energy to burn the area of where the tumor was or where the tumor is located, okay? And usually it's given Monday through Friday, It's fairly quickly, and depending on the indication, you may receive radiation for a few days or you may receive radiation for several weeks. But as I said, it's usually given once a day, Monday through Friday, although there are some exceptions where they may give you radiation twice in a day, but that's usually not the case. Now, radiation can be given, for example, as we already mentioned, if you have stage 3 disease, meaning your mediastinal lymph nodes are involved, they may recommend giving you chemotherapy and radiation together, what we call concurrent chemoradiation. The margins, remember we talked about the surgical margins? Well, if you have positive margins, meaning margins involved with cancer, okay, they were left behind, cancer cells were left behind after surgery, you may be a candidate for radiation therapy. What if you have metastatic disease? So as an example, let's say you have cancer in your bone. Lung cancer has unfortunately traveled to your bone and you're having a lot of pain. Well, radiation treatment to that area can significantly improve your pain. So that's another indication. Controlling bleeding. So I've seen this a few times. You have a lung cancer, and that lung cancer, the blood vessels in that lung cancer are very frail. So you may cough, and every time you cough up some blood. Well, giving radiation therapy to your tumor can burn that area, and in essence, it can cauterize that tumor, and it can really improve or reduce the amount of bleeding. Actually, the times that I've used radiation for bleeding, it's significantly worked. It's really dramatically improved that bleeding issue. Another indication would be brain metastasis. So if the lung cancer has gone to your brain, the doctor may recommend surgery followed by radiation therapy, or if you have multiple brain lesions, they may just recommend radiation treatment to the brain. So these are the more common indications. So, another question to ask is, ask your doctor, are you a candidate for radiation? Are they going to be giving you radiation? And now you have a better idea as to why and what to expect. All right, now let's get into biomarker testing. And I know what you're thinking. You're looking at this slide and you're panicking because this is a lot of information. The good news is that you do not need to memorize this. There's just one thing that I want you to keep in mind. When you have lung cancer, usually, okay, especially if you have more advanced disease, your doctor is going to want to know if your tumor has a specific mutation or a specific finding, because there are treatments that we can give you if you have that one mutation or if you have that one abnormality. So let me go over some examples with you. So let's say you get tested. And by the way, they can test the tumor or they can do this test in your blood. So it's what they call a liquid biopsy if they do it in the blood, or they can do it on the actual tissue, either the biopsy that they did, or when you went for surgery, that surgical specimen that they took out, they can also send this to get analyzed. And they will tell us if you have some of these abnormalities. So as an example, if you have your tumor, if it has an EGFR mutation, you may be a candidate for some treatments. If you have an ALK mutation, you can be a candidate for these treatments. If you have an NTRK mutation, NTRK, you can be a candidate for this treatment. So it's very important to know if you have one of these abnormalities or one of these biomarkers, because if you do, we can give you targeted treatment. We can give you a treatment that specifically targets that mutation. As another example, let's say you have a HER2 protein, we can give you these treatments. So, ask your doctor. What I want you to learn about biomarker testing is ask your doctor, are they going to test you for these mutations, okay? And if they did, do you have one of these mutations or one of these proteins? Because if you do, you might be a candidate for one of these treatment options. Very important to keep that in mind, okay? Now let's talk about chemotherapy, okay? Now I'm not going to get into individually the side effects. That's going to be another video, but I do want to mention that there are some chemotherapy agents that we frequently use in lung cancer, okay? The first family is what we call the platinums, and there's two main platinums that we use in lung cancer. The first one is carboplatin, and the other one is called cisplatin. Now, just some facts. Carboplatin can cause hair loss. It can drop your blood counts. It can cause infusion reactions. Overall, carboplatin is fairly well tolerated, and it's adjusted based on your weight and your height. And they will usually give you carboplatin together with one of these other chemotherapy options. Cisplatin, on the other hand, causes a lot of nausea, a lot of vomiting, and it's toxic to your kidneys and your hearing. So your doctor will take measures, especially a lot of hydration, to try to prevent cisplatin from damaging your kidneys. So as I said, we will usually use one of these two platinums together with one of these drugs down here. So as an example, the taxanes. The two most common taxanes are paclitaxel and docetaxel. They cause a lot of hair loss. They can decrease your immune system. Another drug would be etoposide, another drug frequently used. Another drug that we commonly use is pemetrexed. This is mainly used for an adenocarcinoma, not a squamous cell carcinoma. If you remember from the beginning of the video that there are different types of non-small cell lung cancer, well, this is one area where we have to know which one you have, because we will not give you pemetrexed for a squamous cell, but we will give you pemetrexed for an adenocarcinoma. And there are many other treatment options and many combinations. So what I want you to know about chemotherapy, a lot of times we will give you, for example, either cisplatin or carboplatin with one of these drugs together. And it's usually given every 21 days. So you will get it on the first day, and then 21 days later you will get it, and then 21 days later you'll receive it again. There are other ways we can give it. There's also weekly dosing. It's just a lower dose, just given every week. There are many combinations, many scenarios. Just ask your doctor which chemotherapy agents they will give you. And then if you know the medications, we will take steps to help prevent the side effects. And that's something that you will discuss with your doctor. All right, so now let's talk about immunotherapy. And listen, wake up, you're almost done, okay? But this is very important because immunotherapy is something that we're using more and more of every day, so you need to know about immunotherapy. And as the name implies, immunotherapy works by boosting our immune system, okay? That's just a simplistic way of you knowing what it does. And then hopefully by activating your immune system, your own immune system will attack the cancer cells and start killing them off. Now, most patients tolerate immunotherapy very well. Now, there are some patients that unfortunately, when the immunotherapy activates your immune system, their immune system can also attack your body. And as an example, if it attacks your lungs, it can cause a lot of inflammation and cause what we call a pneumonitis, giving a lot of coughing. Or it can attack your large intestine, causing a lot of diarrhea. It's what we call a colitis. It can attack several areas of your body. Luckily, it's not common. And the good news is that if detected early enough, what we do is that we stop the medication, we stop the immunotherapy, and we tend to start you on a steroid, okay, which is a medication that reduces inflammation. And for the most part, most patients do very well. They recover quickly, okay? But there are many different types of immunotherapy, okay? As an example, these are some: pembrolizumab, nivolumab, durvalumab, atezolizumab. I mean, there's many different options. Your doctor, if they are planning on giving you an immunotherapy, they will likely decide on one of these. There are others, but just know that immunotherapy is something that you might be a candidate for. Now, remember when I spoke to you about the biomarker testing? Well, these tests down here are some of the tests that we look at that will tell us, it gives us an idea how well will you respond to immunotherapy, or if we think immunotherapy is a good option for you. So for example, if your MSI or your CPS score is high, or your PD-1 or PD-L1 is high, or your TMB is greater than 10, you don't need to memorize these. I'm just telling you this so that you have the concept. These tests may tell us that if you have one of these or they're high in number, you're more likely to respond to immunotherapy. So a question that I would have is, to the doctor is, listen, have I been tested for these? Am I a candidate for immunotherapy? And that's the discussion that you absolutely should have with your doctor. All right, so this is the last slide, so I recommend you pay attention and consider writing some of these down because these are very important questions that you may want to ask your doctor. And when you're receiving all these treatments, questions that you should ask is, number one, is chemotherapy recommended? Because let's face it, if you absolutely do not need it, why receive chemotherapy? Okay, because chemotherapy does provide a benefit, but chemotherapy also has its risks. So the question is, do they recommend chemotherapy? Okay, and also, what is the risks versus the benefit of chemotherapy? Also, which chemotherapy regimen will I receive? Will I receive just one of those drugs or a combination? Okay, what pre-medications will I receive? You know, your doctor, together with chemotherapy, is likely to give you medicine to help prevent the side effects of chemotherapy. It's usually anti-nausea medication. They will usually give you steroids like prednisone or dexamethasone. In other words, they will likely give you medicine to make the experience a little more tolerable, okay, to reduce some of those unwanted side effects. So ask, which pre-medications will I receive? And do you require or should you have pre-meds at home? So in case you develop these side effects, you are prepared. The other question is, how many cycles will I receive? Every chemotherapy treatment in oncology, we call them cycles. So the question is, how many treatment cycles will you receive? Okay. Another one is, how often will I receive chemotherapy? As I mentioned, sometimes we give chemo weekly. Sometimes we give it every 3 weeks. So that's another question. Okay. So you're ready. What are the side effects that I'm likely to develop so that you can prepare yourself? Okay. Am I a candidate for immunotherapy? And also the biomarker testing, which I already spoke to you about. And the last thing that I want you to know about is maintenance therapy. And all this means, as an example, sometimes we will give a few cycles. Let's say you had lung cancer, it got taken out, and now we give you chemotherapy, okay? We're giving you, let's say as an example, chemotherapy with immunotherapy. Well, sometimes after 4 or 6 cycles of chemotherapy, we may stop the chemotherapy and leave you only on immunotherapy, which is much better tolerated, okay? And it's what we call maintenance immunotherapy. The whole idea behind maintenance is to try to prevent that cancer from coming back. So that's a question. Are you a candidate for maintenance therapy? All right. So with that being said, we are done. I really hope you found this video useful. If you did, consider liking, subscribe, and share the video. You know, there's probably a lot of patients out there with lung cancer that could really benefit from watching this video. So please share the video and consider checking out some of my other content. That's everything to do with blood disorders and cancer. And all the best to you guys.